Hi everybody, I'm going to do a wrap-up video on fractures. I'm going to do it via computer screen instead of my whiteboard today. So I'm going to bring up some sites here. So let's go to this site. So let's try to make it easy. And actually fractures I know can become confusing because there's so many different kinds. But if you just keep in mind that there are really four main types of fractures. You have the displaced, and all that means is that it's displaced. Like look at the oblique fracture right here. It's displaced. It's not in alignment with each other. The two bones that broke. And then the non-displaced would be here. Non-displaced right in this area. A closed fracture just means that the skin has not been broken through, and the open fracture means it has been broken through. So if you see like an oblique displaced fracture, it can poke through the skin, and that would be more of a medical emergency. When we go down here, it explains what each of the types of fractures are. But if you can look here, transverse just means it's right across horizontally. But then take a look over here at the comminuted. It is a transverse, but it is non-displaced. But look at all these fragments of bone that are in there. So that's called a comminuted. It's a complete fracture all the way through. But what's exceptional about it is that it has bone fragments. Green stick fractures are the most common in kids. Spiral fractures are often seen in cases of abuse. And here's oblique displaced we talked about. And if you see the oblique non-displaced and see how the angle is, that's oblique. And then you have the linear that's going right up down the center of it. Now there's something called a stress fracture, which is a hairline crack, and many people with osteoporosis or osteopenia can get what's called stress fracture. So they're just hairline cracks, and because your bones are more brittle, or it can just happen. Like for example, when I talked about my son getting run over by the car, it ran over his foot, and he has two stress fractures in one of the bones. So perfect example talking about fractures in general. So when you have a fracture, let's say it's a closed fracture, just like my son, he had to be non-weight bearing for 3 weeks. He went back in for his 3-week x-ray, and it looks like it's exactly where it's supposed to be. So now he can start putting weight on it. But so keep in mind that it's not completely healed at 3 weeks. But it is healed enough, as what the orthopedics doctor talks about. It's like this gummy substance similar to collagen that forms in that area, so it becomes more stable. So you can start putting some weight on it. And so also think about when you're doing casting, you're going to take the cast off most likely before it's completely healed. So they still have to watch it and be careful and have a little bit of restrictions on it, but it is pretty well on its way to healing. All right, and then the other thing I want to talk about is let's look at, say, an open fracture where it's broken through the skin. So think of anything that's broken through. What is a risk factor? Infection. So we don't want any infection getting in there, which is why it makes it more of an emergency, as well as because of blood loss. We don't want that. So these people need more immediate treatment, and think about tetanus shot. I'm going to emphasize that, to give them a tetanus shot when they come in. Okay. And then what we do is go to casting here. I'm going to share this video with you. You really don't have to watch the whole video, but just maybe fast forward to like 3 minutes just to kind of watch how they do it. But one thing I want you to take a look at here is you really have to be careful when you're putting the cast on. You see her fingers right here? My thought is that they really shouldn't be there. You should really have your palm of your hand cupped under there, and especially if you have your hand over on this area, because the last thing you want to do is put any sort of indents into the cast, because that's going to cause issues for the patient, because it can cause a pressure sore, it can increase compartment syndrome, etc. So just to let you know that this isn't necessarily correct. So when you watch it, you can see, I mean, for the most part, it's fine. I mean, it's on the heel, but still, you can still get an ulcer, pressure ulcer there, and you don't want that. Don't want to worry about circulation issues. Also, think about this cast. So let's say this is an initial break. Wait 48 hours, because remember, there's a lot of swelling going on. So a lot of times they'll just put like a half cast or wrap it, and they'll say follow up. Then they'll put the whole cast on when they think that the swelling has gone down a lot. So after that, they'll put the cast on, but then you'll probably have to come back in a week or two, just depending, and have it recasted. So you have to take it off, because remember, swelling's going to go down even more, and then you're going to have a lot more room in that casting area. You want to be able to stick at least 2 fingers in this area or in this area. Always look for circulation. You're going to check the toes, but you should be able to at least fit 1 finger through, 2 fingers through that area. Then you know that it's not too tight. If it's more than that, it's too loose. And if you can't, then it's probably too tight. So always watch capillary refill, etc. All right, now what I want to go to is compartment syndrome. I'm just showing this as an example. Look at these 2 pictures here. This is normal, and as you can see that all of this here are different types of vessels, lymph tissue. But when you have compartment syndrome, it starts swelling so much, the muscle starts swelling so much, it starts compressing all the nerves and the blood vessels. And that's an emergency. And so they have to go in and do a fasciotomy to release the pressure of the muscles that are there. So make sure that you understand compartment syndrome and exactly what that is. All right, so also compartment syndrome, think about if you have a cast on or you're taking care of a person with a cast on, what's the first sign? They're probably going to be in a lot of pain. They're going to feel a lot of tightness in, let's say, their lower extremity. Compartment syndrome typically happens in lower extremities, but pain is really the first sign, so you have to always assess for that. All right, let's go to, I want to go to fat emboli. I think I have a fat emboli thing here. No, maybe not. Okay, so fat emboli. Fat emboli is a piece of fat, and usually the clot forms if you have a fracture in one of the long bones. So the lower extremity, most commonly the femur up in this area, and a fat emboli releases into the circulation, and it's just from insult and injury to that long bone. It's a big bone, it's a thick bone, a lot can happen, and you can have more complications. So if you have a fat emboli, it can go up into your circulation, go into your lungs, and as well as get into the capillaries. So the first sign of that, or one of the first signs, is petechiae. So they can get petechiae on their neck and their trunk area, on their upper chest and neck area. Also, respiratory distress is a symptom of that. So make sure you study fat emboli. All right, so now what I'm going to do is go to hip. All right, so you have a hip fracture, and a couple things that you need to keep in mind. Don't forget about Buck's traction. Here's a video, and I'll post the video. You guys, I'm sure, do much better at the sim lab, huh? Don't you guys? Are you guys in street clothes during sim? I'm not sure, but anyways, I did freeze it at this one because I want you to see how they put the boot on. There's 2 of them. You need 2 people to help with the Buck's traction, and there's a tube connected to it. or a rope type thing, I should say, and connected to, they use the IV bag they're using as a weight. You want like a 3 to 5 pound weight connected to it. As you can see, it's hanging. It's not supposed to be on the ground. So if you see that, that is incorrect. And you want to make sure that it's hanging because that is what's going to provide traction. It's giving some pull. And then the foot of the bed is up a little bit to help. So helps with counter traction. All right, so this is usually to stabilize them before surgery because sometimes patients fall at home, end up with a hip fracture, and they're not medically stable to have surgery yet. So they put them in Buck's traction, give them pain medications until they get rehydrated, or say they had a UTI and they give them antibiotics. Now they're all set to go. They end up having a specific type of hip replacement, depending on exactly what they fractured in the hip area. Post-op, remember, they're not supposed to be bending greater than a 90-degree angle. So they should not be bending over to do anything. We have to get them the raised toilet seats. So whenever you're thinking, think about and we all take our movements for granted, so they might not even mean to do it, but they really need to be watched a little bit and taught how, in the initial post-op days, how they need to care for that new hip. Because think about, you just had a brand new hip put in and you don't want to overextend it. Okay, and then the other thing I'm going to quickly go to are amputations. Amputations here, phantom pain. So I just want to show you this picture because it's really, phantom pain can happen immediately after surgery and it can last for years beyond. And it is a phenomenon that scientists, researchers are still trying to figure out exact details about what happens, but we do know that it's a brain connection with the nerves. And they feel as much pain, let's say this hand was amputated, they feel as much pain in this hand as they would if the hand was there. So these people need their pain medication. We need to take phantom pain seriously. Okay, and that is it for the wrap-up video for ortho.